My name's Charlie Irvin, professor of medicine, director of the Lung Center, also assistant dean here at the College of Medicine, and we welcome you this evening for a really scintillating talk, hitting the nerve, sciatica. It's just painful thinking about it, right? And our speaker tonight is, as the dean of the faculty, I get to see everybody's CVs, and Bruce came in and is a professor, so we don't review you, so I haven't had a chance to see his CV before. It's really amazing. Curricula vitae is really the record of a person's accomplishments, their training, and I'm just going to give you a few highlights of that. Bruce, like many of our really fantastic faculty, comes to us from Canada, which is really a good thing. He trained at Queen's over here in Ontario. He then did his residency at Kingston Hospital, also in Canada, and then his residency training in neurosurgery at Toronto, University of Toronto. And then from there, he's been all over the place. I mean, he's been all over the world training. He goes all over the world speaking. He trained in Munich, Zurich, Japan, just to name a few places. He's been on a number of different faculty. I gotta see if I can find that because it was, here we go. He was an assistant professor at a place that I was, University of Colorado. Then he was in Calgary for a period of time, in Alberta, and then came back to the United States because he likes the McDonald's, I guess, I'm not sure why. And was down here at Albany before we recruited him to our faculty. He's a world-class physician scientist. He has over 100 publications peer-reviewed and others, and a number of book chapters. And maybe one of the really telling things for you is that he's been invited to speak all over the world about his expertise. And as I review faculty, that's one sort of thing I look for, because if somebody's willing to pay your airfare and expenses to invite you, that's because they know you're going to do a great job for them. And I know he's going to do a fantastic job for us tonight. So Bruce, take it away. Tell us about sciatica.
Thanks, Charlie. So tonight's talk is about sciatica. It's one of the lumbar spine problems that we commonly see. Sciatica is probably the commonest word that the general public hears about lumbar spine problems, because everybody knows somebody who has sciatica. So when we give one of these talks at the university, we always have to say that we have no financial disclosure, so I don't belong to any spinal company. I have no interest in their finances whatsoever, so this is bias-free. So the plan for tonight is to give a historical perspective about sciatica. Then I'll describe what sciatica is, discuss some causes of sciatica, then present the common presentation of sciatica, how we diagnose sciatica, management of sciatica, and finally, prognosis of somebody who does present with sciatica. So quite simply, sciatica just is taken from the word sciatic nerve. The sciatic nerve is the big nerve that runs down the leg. And commonly, we think of sciatica as pain that starts in the lower back and radiates through the buttock region into one or both legs. Sciatica is caused by pressure on the sciatic nerve or the nerves from the spinal cord. The sciatic nerve comes from nerve roots that come off the spinal cord, and then the nerve roots join to make the sciatic nerve. So people present with pain in their leg. Everybody thinks it's from the sciatic nerve, but it most commonly comes from the pinched nerves in the spine. And that just depicts, I'll show better pictures, but that just depicts a lumbar disc with the herniation, pushing on the nerve root as it comes out of the spine. So some anatomy first, just so you know what we're talking about tonight. This is a view that we see every day. It represents the lumbar spine. Everybody knows that we work from MRI scans now. And so we call that a sagittal view, so a picture from the side of the spine. And then we call these axial views. These are views looking down on the spine. So quite simply, I'll probably use some common slang that we use in the office. So I'll just introduce the slang words as best I can now. So we call, there are 5 lumbar vertebrae. So we call it L2, L3, L4, L5, and there's the sacrum. The spinal cord normally stops or ends at about L2. And then the rest of the spinal cord isn't spinal cord, but it consists of nerve roots. And at each level, a nerve root comes out. So when we describe somebody as having an L4-5 disc or an L4-5 problem, we're usually talking about the nerve root as it comes out at that level. So that's L4-5, that's L5-S1. And sciatica, again, involves the buttock pain and leg pain. So we're dealing with the lower spine here. Has nothing to do with cervical spine or thoracic spine. So this is the cross-section that we see on the MRI scan. I'll be showing an MRI scan later. And this is the disc itself. The disc consists of some jelly in the middle. And there are what we call annular fibers that hold the disc inside. And then if you take a cross-section through there, those are the nerve roots at L4-5 or behind the 5 body. So those are nerve roots. Again, spinal cord ends up here. And this is the back of the vertebra. That structure is called the lamina. And one of the terms that you'll hear tonight is laminectomy, meaning take off the lamina. So that's the back. Those are the nerve roots. That's the front of the disc. So then the word sciatica, again, comes from the sciatic nerve, pain in the sciatic nerve. So spinal cord ends up there, the nerve roots come down, and there are about 3 or 4 main nerves that make up the sciatic nerve. So we call this a plexus. So it's L2 or L3, 4, 5, and S1. So spinal cord, so the nerve roots, the term we use is cauda equina, means horsetail. And so the anatomists early on saw that these nerve roots looked like a horsetail, so that's where we get that word. Then the spinal nerve roots, and then the sciatic nerve. And this picture just shows some of the anatomy and the pathology that I'll be showing later. So herniated disc, there's the disc, that's the spinal cord. So from the disc herniation, one can get pressure on the spinal cord. Nerve roots, there's a nerve root going out. Remember, at each level, there's a nerve root going out. So that could be the L5 or S1 nerve root. And then the spinal cord itself, or the cauda equina, or the nerve roots can be. Was that the end of the soccer game? And so there's pathology back here, there's problems back here that can pinch on the spinal cord itself. So people come to the clinic and they ask about what a herniated disc is or what stenosis is. So these are terms that people come into the clinic saying, what's a herniated disc? Is it the same as a bulging disc? What's a slip disc, protruding disc, fragmented disc, or what's spinal stenosis? So these are more or less the same thing to those of us that look at spines day in and day out. You could say that a bulging disc, however, is just a little bulge there, but to the public, it means the same thing. It's a problem with the disc compressing a nerve root of the spinal cord. Sometimes the disc herniates entirely, so that disc fragment goes out into the canal. Slip disc probably just means the same as a herniated disc. And then spinal stenosis. Most people know what stenosis is. And what it is this compression of the spinal canal there, either by disc or by degenerative changes or arthritis. So this all seems very common, and we all take a lot of it for granted. But I thought I'd start off with a story back in 1930. So remember this, 1930. And here's the case presentation. 25-year-old male from Vermont. He's out skiing in March 1930. He develops pain down his thigh into his calf. He's admitted to Mary Fletcher Hospital, which is right here. And the doctors, no neurosurgeons or no spinal orthopods were here. So the surgeons put him to bed, and he improved. So 2 years later, he's out skiing again, and he re-injures his leg. Gets left leg pain. They don't know what it is, but it sounds like sciatica. Back then, they didn't really know what caused sciatica, so they sent him down to Mass General. And the experts down there have a look at him. The exam shows severe left leg pain, absent ankle reflex, tenderness along the sciatic nerve, all signs of sciatica as we understand it today. They thought it was a spinal tumor, something compressing on those nerve roots. So July 1932, they take him to the operating room, and they find this funny thing. They didn't really know what it was. They described it as a fine or a firm nodule compressing one of the nerve roots from L5S1. They take it out, and the patient's all better. So that is the first description, the first operation for a herniated disc. And it's unbelievable that something so simple took until 1930 to discover and help people. And what makes it more interesting is that Donaghy and Frymore, Donaghy was the head of neurosurgery here, and Frymore was head of orthopedics here, and it was their patient, and they did a follow-up on him in 1946, and he was still fine. So 1930s. So what happens today? Oh, these are the Donaghy and Frymore wrote a paper, and they got the original OR note. So that's and Mixter and Barr were the surgeons, and they're very well known from NGH as making this discovery. And that's one of their signatures. You can't read it. Anyways, that's what a herniated disc looks like, and they made a drawing, and there's the S1 root, and there's the disc herniation right underneath. And they describe what they did in piecemeal fashion. So that's just a blow-up of it. So today, there's a patient that I saw recently. He's a laborer, 40 years old, twists his back at work. A couple days later, he develops right leg pain, numbness, and weakness. Sounds like sciatica. So the family doctor sees him, puts him to rest, gives him some medication, no improvement, goes back to see his PCP, gets physical therapy, no improvement, patient can't work, can't sleep, can't do anything. Finally, he says, you gotta do something. So the family doctor, 6 weeks later, does an x-ray, and then finally gets an MRI scan. So here are the x-rays. We always get x-rays on patients. This is what we call an AP of the lumbar spine. Looks pretty normal. And there's the lateral that we always see as well. Some degenerative changes, but overall, pretty normal. This is the MRI scan. And the MRI scans are so clear these days that anybody can see the pathology, and there it is right there. So between L4 and L5, there's the disc herniation. Then you take a slice across here, there's the disc, that's the belly up front, that's the back. This is the spinal canal. Those are the nerve roots are called equina, and there, that big black thing is the disc herniation. So simple disc herniation. So MRI scan shows disc herniation, L4-5. The guy presents with sciatica. He can't do anything. I see him and recommend some more conservative therapy. He's getting a little bit better, but after 12 weeks, he just can't stand it anymore. He's got to get back to work. Do a little what we call microdiscectomy, and I'll show you that later. He goes home the next day, all better, and slowly the power and the strength, or the power and the sensation return. So, sciatica. When we see a patient coming into the office, what do we think of? By far the most common thing that the patient has is a herniated disc. But other causes, spinal stenosis. Spinal stenosis we see in older patients. It's a form of an arthritic or a degenerative change of the spine caused by arthritis. This is a word meaning bone slip, spondylolisthesis. Sometimes in older people, we see the spine slip. Rare spinal cord tumors can cause sciatica. Some patients occasionally come in with spinal infections. We call an epidural abscess. Tethered cord is a term that some of you may know, have heard of. It's a form of spina bifida, and that can be present in kids or in adults. And what it is the spinal cord is tethered or made tight by some congenital problem. And then the thing that a lot of people forget is that you can get sciatica from a nerve or from a tumor in the nerve itself. So if we see a patient who we do all the investigations and he really has sciatica and we don't find anything in the spine, then we start looking down the leg. But they are pretty unusual. So I'll talk mostly about herniated discs because that's the most common cause of sciatica. And that's that picture, that's that MRI scan. This shows, and so that's the herniated disc compressing the nerve roots. This is the disc. And again, it's jelly in the middle. We say it's like a jelly donut with the jelly squirting out. And it sits in the canal, pushes on the nerve root. And that's where the pain comes from, because that nerve root has pain fibers, motor fibers, and sensory fibers. And when the disc presses on that, then those are the symptoms the patient gets. It's very common in mid-age. And as I said, the disc material, the jelly squirts out and pinches the nerve root. Associated with severe pain, back pain, buttock pain, and not just pain of sciatica, but if the disc herniation is large, then the patient will have weakness of its leg or foot and associated numbness. Within 8 to 12 weeks, 70% of the patients will get better on their own, or what we call conservative treatment, and I'll describe that later. Occasionally, surgery is necessary, which those two gentlemen that I presented required. Spinal stenosis, seen in older patients. It's due to a combination of arthritic changes in the joints around the spine, plus bulging disc. So that's what the canal should look like there, wide open. So that's where the nerve roots come. The white color there is spinal fluid, so that's the spinal canal. And that's wide open. That's not bad. But you see there's no space for the nerve roots. Again, a degenerative arthritic change, and at that level. So that's L2, 3, L3, 4, spinal stenosis. And you hear the nerve roots trying to fall down, and they look redundant up there because they can't get through there. So that'll give, amongst other symptoms, sciatica, the sciatica that we see in these patients. So very common in older patients. And again, it's a benign entity just caused by aging. Other causes, spinal tumors. not very common, but we see them. Can cause just sciatica, but also can be associated with weakness, numbness, and bladder bowel problems. There's the spinal canal. Those are the discs. And this is a younger person. You can see how the spine looks healthy. The discs are nice and plump. And there's this lump down there and there, compressing the nerve roots. So the nerve roots are being compressed. The patient has pain, numbness, and weakness down the legs. Most of these tumors are benign. A lot of them we see in mid-adulthood. They squeeze normal nerve roots, and since the tumor compressing the nerve roots, the only real treatment is surgery, and just take the tumors out. But again, most of them are benign, slow growing, so the patients do well. Tethered cord, this is an MRI scan showing this is actually fat that's a fatty tumor, very, very benign, but it's causing the spinal cord to be tethered down there. So because the spinal cord and the nerve roots aren't moving freely in the canal, the patient will get sciatica from that. And this other entity that some of you may have heard of, the spondylolisthesis, it's just where one of the vertebrates slips on another. And we're not really sure why these patients get the slip. We see that there's a fracture in the vertebra, but where that fracture comes from, it's not a traumatic injury. It's something perhaps congenital. We can see it in teenagers or adults. And a lot of patients get better with conservative therapy, but may need surgery. So sciatica. Again, we've talked about it over and over, but simply sciatica, the presentation, burning pain. The pain can be severe. The patients just scream with pain. It starts in the lower back, goes to the buttock, and it's electric-like shock from thigh down to the foot. Can be associated with numbness or weakness. And depending on what nerve root is being pinched, we can make the diagnosis of what discus or what disc herniated or where the spinal stenosis is. So that's an L5 root that goes through the foot, S1 to the bottom of the foot. And the patients are treated conservatively unless they just can't stand the pain or numbness or weakness. Risk factors. We know that mostly middle-aged people get herniated discs. Older people get spinal stenosis, so that sort of puts them into categories before we even get an MRI scan on them. People who are overweight are more prone to get sciatica and back problems. Patients, laborers who lift heavy objects, movers, construction workers tend to get spine problems, sciatica more often. Patients that do a lot of sitting, be it truck drivers, are prone to sciatica. And we see pregnancy. We see women coming into the clinic with sciatica because of that. That puts stress on the back and causes discs to herniate. So patient comes into the clinic, how do we diagnose it? Take a history. So there are clues what the patient does, how old they are, what their symptoms are, pain down the leg, what distribution, what nerve root do we think it is. Then the physical exam, are they weak, are they numb? Some other signs that we look for. We do x-rays like the x-rays that I showed you previously, MRI scan, so we put them into that big, long, hollow thing that everybody hates. Sometimes patients can't tolerate it, so we have to sedate them. But by far, the best diagnostic tool we have is the MRI scan. Sometimes we have to resort to a myelogram with a CAT scan. CAT scan shows bone, but it doesn't show soft tissue, so we have to, and this is the old test that we did up until 1990. We still do it, though, in patients who have cardiac pacers or some sort of pacer or degenerated for other reasons in them. And a myelogram is where the patient gets a lumbar puncture and dies put in the spine. So that's the patient going through the MRI scan. Other things that we use to diagnose patients with sciatica, we're trying to find where the pain's coming from. EMG and nerve conduction tests, that's where the neurologist will stick needles in muscles and skin to determine what muscles aren't working or what nerves are not working. And we often will send a patient for a diagnostic steroid block where the pain specialist will put a needle by that nerve root, freeze it, or put steroid on it. If the patient gets better, then we know that we have the correct location, correct diagnosis, or if it doesn't work, then we go looking elsewhere. So those are the ways that we diagnose causes of sciatica. So how do we manage these patients? So we use the terms conservative therapy versus surgical treatment. Most patients get better with conservative therapy. And simply, we think of the conservative means as medication and physical therapy. So what do we use? Anti-inflammatory agents are probably the best medications that we can prescribe. They're safe. Most of them are safe. And they are effective because we're trying to decrease the inflammation around the nerve roots. So things like Motrin and Aleve, those are very common medications. Muscle relaxants, herniated discs or spondylosis produces muscles to go into spasm, so muscle relaxants we prescribe. We don't like prescribing these guys, but sometimes the pain's so severe, a short course of narcotics gets the patient over the crisis, and then they wean off very quickly. Oral steroids, patients are put on prednisone or what we call Medrol dose packs. And those are very strong anti-inflammatory agents. So a short course of steroids, they're stronger than anti-inflammatories. Other medications that you may have heard of, Neurontin and Lyrica. These drugs were actually produced to treat seizures, but people soon discovered that they were good for modifying the sensation of pain. They don't attack the cause of the pain at all, but I say they trick the brain into thinking that it doesn't hurt quite as much. Sometimes they're very successful, but again, they don't treat the problem. Then pain management clinics. We have many pain management clinics in this area. So when a patient isn't getting better, but we think that a patient get better on its own without surgery, we'll send patients to pain management. And some of the clinics will treat with injections. So put a little steroid down by the nerve root, and maybe that'll buy time, or it will settle the pain. Some will sort of be all inclusive. Treat with medications, do the steroid injections. They do have psychotherapists, physical therapy, all the modalities I would think of as conservative techniques, just trying to get the patient by, either for the disc herniation to shrink up, because disc herniations do shrink up, or physical therapy can cure or modify the pain of spondylosis or the other disease I've talked about, the slippage, the spondylolisthesis. So physical therapy, we send most patients, or all patients, to physical therapy. The reason being is that strengthening the muscles of the spine, of the abdomen, of the pelvis, it does modify the biomechanics of this lumbar spine, and that may get the patient by without surgery. Chiropractic manipulation, that may also help. People say, well, should they go to physical therapist or should they go to a chiropractor? There's often a lot of overlap, and as long as the chiropractor isn't too aggressive, or sometimes the physical therapist can do gentle manipulation, it doesn't really matter. But when we send a patient for physical therapy or chiropractic manipulation, we know what the physical therapist is going to do, and we do write out prescriptions describing what the best management is, along with the diagnosis, so they do know what we're treating. Steroid injections, again, they can be used for diagnosis, but we also use them as treatment, putting some steroid down by the nerve root or down by the spinal cord can settle down the inflammation to the point where the patient gets better and doesn't need any surgery. Other remedies that we prescribe and patients ask about, acupuncture. It's effective, but it's temporary from what we see. But again, to get somebody through a crisis, it may work. I tell my patients backs love water, so aquatherapy is really good. And then physical therapists use hot and cold packs. I normally just tell the patient to use warm packs because mostly what they're complaining of and what's making the condition worse is muscle spasm. So those are the conservative techniques for the non-surgical. So for sciatica, and mostly for herniated disc, but it holds for the other conditions as well. Sciatica again is pain, may be associated with weakness. So we treat patients conservatively, wait. If they're dying with pain, they just can't sleep, they can't do anything, then we'll say, okay, then perhaps a surgical procedure will help, and we start talking surgery. Patients who have marked weakness of their foot or their leg, again, that's an indication for surgery. We see patients with foot drop, they're tripping over their foot. That actually is a true indication for urgent surgery if the appropriate pathology is seen on the MRI scan. Normally we wait 3-4 months before recommending surgery for patients who are tolerating the pain, but they just don't want to live that way. They can't do everything that they want to do. Try the conservative techniques until finally they say, just do something, I can't take this anymore. And the other indication for surgery is bladder and bowel loss. So if the stenosis or the disc herniation is large enough, pushing on all those nerve roots and they don't work, then it's an emergency that they do need surgery and really take the pressure off those nerve roots. So the other thing that we hear in the clinic are all these terms. Patients are confused about terms. Even we're concerned, we're confused about some of the terms and what people are all talking about. So discectomy. This simply means taking the disc herniation out. We do very little in the disc space. The lump is out here. The lump is of disc. The herniated disc is pushing on the spinal cord or the nerve root. For a discectomy, we just go in there. Try to keep as much of the normal disc as possible. Laminectomy, as I showed before, the back part of the vertebra is the lamina. So if the lamina is overgrown as a lumbar stenosis, and the canal, instead of being that large, is that large, or really small, then that whole lamina needs to come off to give the contents of the spinal canal some room. So that's a laminectomy, means take the whole back off. Normally, that's well tolerated. It's one of those excess pieces that God gave us that we don't need. Laminotomy, means just take some of the lamina away, Sometimes we can get away with just taking half the lamina, and that'll open up the spinal canal enough. Foraminotomy just means where that nerve root goes out, we just take away bone to give that nerve root some room. That joint is often in spinal stenosis overgrown, and so the bone spur is there pushing on that little nerve root. If we just open up that space there with a drill or bone biters, then that nerve root will get relieved of the pressure. Fusion. Occasionally, fusions are necessary for these spinal diseases. And I'll describe them in a few slides. But for simple stenosis or simple disc herniations, often a fusion isn't necessary. The risk of surgery, this one reason that we don't jump in and do surgery right away, because every surgery has a potential risk or complication. For common surgery that we do, the risk is minimal, maybe less than 5%, but it's there. And if it happens, then it can be disaster. So, infection, neurological injury, the nerve roots can get injured or the spinal cord can get injured. The patient can be left with a deficit that they didn't have before. If that nerve root or spinal cord are pinched, then the patient can end up with worse pain. The spinal fluid leak, there's what we call the dura wraps around the nerve roots. That can get torn during surgery, and that spinal fluid leak can be a nuisance. There's always the anesthetic risks. They're minimal, but they're there, especially with people who do have harder pulmonary problems. Sometimes patients don't get better at all. Maybe it's the wrong diagnosis, or pathology is missed, or maybe the nerve root or spinal cord has been pinched too long. And sometimes patients will come back after spine injury or spinal surgery, come back 3 or 4 years later, need more surgery, and they sort of look at the surgeon and say, well, it's your fault. Maybe, maybe not, but it's a consequence, maybe a consequence of the surgery. It may just be the natural history of what was going to happen anyways. So, all the things to think about before doing surgery. So the commonest surgery that we as spinal surgeons do are disc herniations, so discectomies. And as I said, we just go in and take the fragment of disc away from the nerve root. And of all the patients we see with disc herniations seen on MRI scans, so true disc herniations, probably only about 10% will ever need surgery. Now there are different terms, again, terms that are used that are often confused and have different meanings. So somebody comes in, they need a discectomy, they need disc surgery. These are all the options that are out there. So lumbar discectomy, just a straightforward discectomy means taking the disc out. We're taking that fragment away from the nerve root or spinal cord. Microdiscectomy, the micro just means that we use a microscope, so smaller incision, better lighting, safer. Just means, again, using the microscope. Then you'll hear this term minimally invasive surgery. That makes the incision smaller. There are devices that the spine companies are putting out for this minimally invasive surgery. Some of it's gimmetry, some of it is beneficial. It's still, there's a lot to learn about minimally invasive surgery. It's in its infancy. Laser spine surgery. Everybody says, comes to clinic, oh, you're going to discectomy, are you going to use the laser? Everybody's heard about the laser spine centers in Florida, they're in Philadelphia now, they're coming up the coast. Be careful. Just read the fine print. To take a disc, to relieve pressure off the nerve root or off the spinal cord, you need surgery. Laser is just a high energy source to shrink up things. It may have a small role in spinal surgery, but for routine surgery, the laser isn't necessary. And that's all I'm going to say. Be careful. Percutaneous techniques sort of goes along with minimally invasive surgery. Percutaneous techniques, so push the envelope a little more, where with the patient awake, putting a needle into the disc space and trying to get the disc herniation to be sucked back into the canal, or shrinking up the disc enough that the pressure will be taken off and the disc herniation will go away. When I was a resident, we used to use kind of pat pain, and there are numerous centers testing chemopad pain. What it is just papaya juice squirted into the disc space, and it was supposed to shrink up the disc. It never did, and people stuck lasers in the disc space. There's a thing called IDET that was popular maybe 10 years ago. It's a thermal burning of the disc itself, shrinking up the disc. Again, most of those techniques have fallen out of favor. They just don't work as well. Fusions for lumbar discectomies most often aren't necessary for simple disc surgery or simple spinal stenosis. If it is necessary, then there are lots of techniques. It can be done from the front, from behind, but it always requires, or almost always requires, metal, screws, plates, and makes the surgery more complicated and more dangerous. So it's try to avoid it at all if we can. So, one of the things that we show patients in the clinic, oh, here it goes. So this is a cartoon that we show patients, and this is showing a simple discectomy. So incisions made, it's done under general anesthetic. That's what we call fascia being opened down to the bone. So this is the bone being drilled to get the access from behind just a little bit better. And then there's what we call the yellow ligament that we poke through to get a good look. So there's the nerve root reddened by the disc herniation. So this is bone, nerve root, and move the nerve root aside. There's the disc herniation, disc space. And so the lump's gone. And that's a simple discectomy. So the next one is real surgery. So if anybody doesn't like blood, I'd watch the soccer game for a few minutes. So this is bone here. That's the nerve root there. That's the disc herniation underneath that nerve root. The nerve root's reddened. There we're trying to free up that lump there. Just so you know, this is the computer, not us, jittery. So there's the fragment coming out. A simple discectomy. So that's a disc herniation, common surgery, simple. So other surgeries that we do for sciatica, lumbar spinal stenosis, again, it's in older patients. Most of these patients get a laminectomy, meaning open up from behind, take bone, take the arthritic material away, and relieve the pressure on the nerve root. That's spinal infections. Sometimes we get away with antibiotics, but if there's a large abscess in there, then they need surgery. Tumors need surgery. And the slip disc, or what we call spondylolisthesis, often they'll get better with physical therapy, but if not, they get this surgical fusion. So here's the fusion. That's the slip already corrected. So a fusion, screws, and then a rod that joins the screws, and then there's bone laid down around the screws. Prevention. This is what we can do to minimize our chances of getting sciatica. Exercise. Strengthen the core, strengthen the back, strengthen the abdomen. Proper posture. Posture is really very important in looking after your back. Weight obviously is a real risk factor for a bad back. And then good body mechanics. Learn how to lift, use your legs. We send everybody to physical therapy even after surgery to learn all this once again. Prognosis, conservative versus surgery. Most patients recover with conservative therapy. If surgery is necessary, they also do well. The goal of treating sciatica is get rid of the pain. So again, conservative PT, medication. Herniated disc can shrink up on their own, so that's why we wait 14, 16 weeks. And then always remember surgery is the last resort. We can always do surgery. Sometimes it's urgently needed, most times it's an elective procedure. So for the appropriate patient who has the disease, the appropriate disease, with surgery, 90% will get better. And that's all I've got, so I'd be happy to answer any questions. Yes, sir.
Suppose someone gets a herniated disc from lifting too much, and it gets better with conservative treatment, and then the symptoms come back 3-4 years later. Is that a new injury, or is it possible that it would just come back like that?
Herniated disc can re-herniate, but a disc at L4 or 5 can also get better, and a new one occur at the level above or level below. So without an MRI scan, you don't really know. Or sometimes the patients say, oh, the symptoms are exactly the same. Then it's, you more or less know that it's the same disc, and just more material has come out. So the original disc herniation shrinks up, and then more can come out. So yes.
Can you expect it to come back periodically then, forever?
Sure. Most often they don't shrink up entirely. So with age, the spinal canal does get smaller because of arthritis. So even if the disc does shrink up to a degree, then with the additional arthritis, the patient may get symptoms from the shrunk up disc, but also from stenosis or the bone spurs.
If you've had sciatica once, what are the chances of having it again?
I think there's just minimal over the normal population, because disc herniations can shrink up and go away. But if it's due to spinal stenosis, then those bone spurs aren't going to go away, so probably it's going to be recurrent. So younger people, episode of sciatica goes away, probably be fine. But older people with stenosis, no. It will come back. But we see patients who have stenosis, they have an MRI scan, they waffle about surgery. And that's fine. Let's see how they do. We don't see them for 5 years, and they come complaining of their neck rather than their back and say, what happened to your back? Oh, it's all better. I haven't thought about it. So, it's a mystery often. Okay.
My father suffers with leg pain that goes away almost immediately once he sits down. 20 seconds later, he's fine for another 200 feet maybe. My question to you is, walking with the pain, is that causing any damage or is it just pain? If he tries to walk through it,
So the question is, if you have pain, are you hurting yourself more by walking and creating pain? You probably are, because the nerve root being irritated. It's probably micro injury, but over time and time over, it's probably not a good thing. And it's when you have pain, it's the body telling you not to do what you're doing.
But the issue is the pain is relieved upon sitting. And if he does, oh, he can't sit, I gotta get to there before I can sit down. Well, he's gotta make it to there before he can sit down. Forcing his way to that spot is he causing more injury to himself, et cetera.
Yes.
Could you describe the process of the herniation shrinking up?
The process of why does the disc herniation shrink up? We don't know. Two explanations. The body has some enzyme sitting around. There's some, it's like an infection or some inflammatory process where white blood cells go in and sort of eat it up and emit some enzymes that shrink up the disc. Probably more likely, disc herniation shrink up because when they herniate, they're juicy and moist, and when they're out in the canal, they get hardened and they get dehydrated. So it's probably just a process of dehydration. But again, it's just conjecture.
I have a question about the infection that might cause sciatica. Are there common causes of infections that lead to that, or is it just kind of spontaneous?
We see patients with these abscesses that are spontaneous, but we always ask certain questions. So there are some clues. Dental work. Whenever somebody has their teeth done, you get a bacteremia, and occasionally that'll cause an abscess. More commonly, we see it in patients who abuse drugs, IV drugs. Those are the two common ones.
If you, as I do, I experience this symptom of the buttock region being inflamed, but it is so localized, never goes down my leg, and it's very irregular, sometimes triggered by exercise, sometimes triggered just by sitting, other times no discomfort at all, comes and goes, it's been there for years.
It can be a root being pinched. It can be a herniated disc. It can be. Just buttock pain right there. Yep, it can be a herniated disc. Can be, but there are other things. Where you're pushing is called the sciatic notch. So you saw my description of that in the 1930s. One of their physical exam points was that they pushed on the sciatic nerve and it was tender. So if you push right in the sciatic nerve or sciatic notch, you push on the nerve, and that can represent the nerve being pinched higher up in the spine. It can be other things too. People will call it piriform syndrome. It can be pain coming from a joint around the spine. It can be those other things like tumor or something. But if it is there and doesn't change dramatically, it's probably a small herniation irritating the nerve root.
Which is why we'd be sometimes there, sometimes not.
Yeah. Again, it depends on posture, shoes you wear, what you're doing, simple things. Go ahead.
Herniated disc at one level, and it's been surgically repaired. Are you likely to get one at another level? Are you more likely to get herniated disc at another level than someone who's never had one?
So if you've had surgery at one level, are you more apt to get a problem at another? Yes. What percentage? A small amount. Just because your biomechanics, the back that you've had for so long, the biomechanics are messed up by the degeneration. By the surgery is going to affect it a little bit. So you probably are at risk, and so that's why we send all patients after the surgery to physical therapy to try to improve their habits. Go ahead.
Of the various cases you talked about, what are the chances of permanent loss of full leg strength?
So the question is, what would cause an entire leg to go weak? or paralyzed? Weak. To make the entire leg go weak, it has to be upstream, so higher up. So it can be a disc at L1. It can be a tumor at L1. Anything higher up. But you would expect both legs to be affected. But you still can just get one leg affected just because of the location of whatever it is in the canal. But again, it doesn't tell you what the disease is. It just tells me sort of where it is.
So my understanding is that can they or can't they definitively diagnose the pain is involving the spine until they do an MRI?
It just makes, is an MRI scan essential in diagnosing a spine problem? No. It just makes us and the patient more confident. So if somebody comes in with classic sciatica, they're lifting something, they get a sore back, and then they get a painful leg, and they have numbness and weakness, you know that's the back. You're not always sure where it is. Could it be mid-lumbar spine or lower lumbar spine? That's one of the reasons we use the MRI scan, is to confirm what we're thinking and where the problem is and what it is. But there are cases that are clear-cut. That's a spine problem. There are others that we're not sure, and then we start doing all those diagnostic tests.
What about things that mimic sciatica? This gentleman mentioned more localized and not the complete picture. And what about trigger points, for example?
Sure, absolutely. There are hundreds of reasons for buttock pain or leg pain. Common things are common, though.
Does inversion help for herniated disc hanging upside down?
Inversion. Those inversion tables where they hang you upside down. In a certain percentage of people, I would say yes. And the reason is that if you have a herniated disc and it's new and juicy and sitting there, if you unweight the spine, or you just go swimming, that's cheap, instead of going to get one of those things, it unweights the spine. So it can give you temporary relief. So if you have severe sciatica, the fresh disc, you hang upside down, you could unweight yourself enough because your weight is pushing that disc and pushing the disc fragment out. So if you unweight it, it may relieve it a little bit. But more often than not, it's not. But it can help. Let me see. Piriformis muscle. So it's often misdiagnosed because piriformis muscle is here. It causes pain right there. And there's the piriformis muscle. The spine's up here. That's the hip. There's sciatic nerve. So it's thought that if that muscle, piriformis muscle, is inflamed, if there's tendinitis from it, it can pinch the sciatic nerve. It's often misdiagnosed because of the problem here, that there's pain in your butt. That's more likely a herniated disc than piriformis. But again, it's part of the examination, part of using the MRI scan and diagnostic blocks to try to figure it out. Pain specialists can put steroid right there, and that's a simple test to see if it is piriformis or not. That a pain specialist can do an injection there, a steroid injection, and that can be diagnostic for piriformis. Can be. Yeah, or around the muscle. It's like tendinitis anywhere. Go ahead. Stem cells, they're looking into stem cells as regenerating the disc. So people have degenerative discs and herniations, putting stem cells in. So that's one area of research. Using an endoscope. Some people use an endoscope like a laparoscope, use an endoscope to make a smaller incision, go down and look around the nerve root and the disc, and take the disc out that way. And that was probably where the research is going. The research is really surgical, is this minimally invasive surgery, how you can get in and out without smallest incision and without irritating the muscles. And then the regeneration, everybody's into trying to regenerate that disc.
How large was that incision you were showing on the actual video?
Oh, that was too big. So the question is, how large is the incision? For just a one level, I don't know, it's about an inch and a half to 2 inches. It's not very big.
A lot of pain radiating down. I also have tingling. And if I'm laying down, if I turn over, then it relieves it. Is that common?
Sure. So tingling is what we call numbness. We use all different terms for loss of sensation or funny or abnormal sensation, paresthesia, tingling, pins and needles. So that can be a symptom of a pinched nerve. And so when you change position, you take the pressure off. One last one.
Spinal stenosis diagnosed last August. And the last 6 weeks or so, I would say that sciatica on the right side when driving has blossomed far too big time in my life. Do you have any recommendations other than, stop every 10 minutes or something? And that I live an hour away to get up here for the talk tonight. So how do you cope with that?
Do the conservative techniques. So medication, anti-inflammatories, physical therapy. Go to a physical therapist that is an expert in backs. And what they'll do is change your body posture, body habits, just so the forces that you generate doing what you're doing to aggravate the nerve will change. So physical therapy and all those other tricks that I had there that don't work, then you're stuck considering surgery. All right, thanks everybody.